All right, thank you very much. So I have a confession to make. I have never used the Anaconda device. I have received money as an advisor from Anaconda. I first became interested in this question actually from happenstance. So I was discussing with a basic science researcher how to induce ventilator-induced lung injury in a rat. And he complained that no matter how hard he tried, he couldn't do it. And I asked him what he was using for anesthesia, and he said sevoflurane. And that anecdote got me thinking, you know, there may be something here. And if we look at our anesthesia practice, we ventilate around the world hundreds of thousands of patients a day. So anesthesia is extremely common. Anesthesia with volatile anesthetics, of course, is common. But the incidence of lung injury following anesthesia is actually pretty rare. And why is that? Now, one reason may be that it's a short duration. It may be that we are awesome anesthesiologists, but there may be something else there. So volatile anesthetics have been used for surgical anesthesia since 1846. I'm from Boston. That is a painting of the first anesthetic at the Massachusetts General Hospital. By the way, that operating room is still there, and if you're ever in Boston, it's worth walking through and visiting. Anesthesia has generally been very reliable, very titratable, and very safe. The mortality from anesthesia per se is now vanishingly rare. But our talk today is about the non-anesthetic effects of volatile anesthesia. And we know that volatiles can induce muscle relaxation, bronchodilation, but they also probably, apparently, induce organ protection. And this talk will concentrate on protection of the lung. So probably the most known effect of volatile anesthetics is bronchodilation. It's been used in status asthmaticus in the ICUs. That is probably the first use of inhaled anesthetics in the ICU. And this is a paper from anesthesiology 25 years ago showing the response to an antigen challenge and the resistance of the airway following the antigen challenge. And you can see that the bottom two lines are sevoflurane and isoflurane, and the restriction is significantly attenuated when you sedate the patient with volatile anesthetics. In children, this is actually common, as asthma is more a disease we see in children, and severe asthma, life-threatening asthma is more seen in children. Here you can see on top a graph of the patient PCO2 over time following use of inhaled anesthetics. And you can see that it goes from really life-threatening levels to relatively normal levels. And the table below demonstrates the rest of the blood gases. So a pH going from baseline at 7.13 to a normal pH at the end of therapy. So bronchodilation, use of inhaled anesthetics in asthma is not common, but well described. And those effects would also mediate lung injury. Anti-inflammatory effects are myriad in inhaled anesthetics. They reduce neutrophil migration to the lung. They limit the release of inflammatory cytokines by those neutrophils. They upregulate reactive oxygen species, which protect the lung, and they inhibit nuclear translocation of NFK. All of these together are inflammatory modulation by the inhaled anesthetic, all of which we can predict will protect the lung. This is an interesting study from several years ago. I'm using a two-hit model of perioperative lung injury. So they induced aspiration and ventilator-induced lung injury, both in live rats and in cell models. They then looked at the histology of these animals. So above you can see the control animals. Below you can see the animals with isoflurane, and you can see 3 levels of lung injury. And in each of those levels, the inflammation, the thickening of the capillary, of the alveolar membranes, the migration of neutrophils into the alveoli are all attenuated by use of inhaled anesthetics. So if we think about our patient with ARDS in the ICU, this is as close a model we can get in an animal to that ARDS. It's not only attenuation of inflammation, so this is a study the same study looking at the tight junction proteins, so the barrier protection of the capillary. And you can see in the control animal, it may be faint, but you can see the red coloring marked by arrows. Those are tight junction proteins. In the middle plate, you see that red has disappeared. And in the animal protected by isoflurane, you can see that those are preserved. So it's not only the inflammation, it's actually protection of the structural integrity of the alveolus by the inhaled anesthetics. Human studies. So human studies examining the topic of lung injury are actually pretty rare in the ICU, so we have to go back to our anesthesia studies, and there's no reason to think that they wouldn't be relevant. So here we see patients undergoing thoracic surgery. So thoracic surgery is pretty well designed to beat up the lung. And here we're looking at the inflammatory mediators in patients who were sedated either with Propofol or inhaled anesthetics in the non-operative lungs. So when we do thoracic surgery, I'm sure there's many anesthesiologists here, we lay the patient on their side. We only ventilate the lower lung, and this is showing that lower lung is protected from the production of inflammatory mediators by inhaled anesthetics. Interestingly, it's not only the lower lung, the open lung, it's also the operated lung. And you can see here in this graph, the operated lung is also protected. Now that's in spite of the operative lung undergoing significant mechanical stress as it's stretched, as it's stapled, as it's pushed around, as it's deflated. So there is protection from inflammation by inhaled anesthetics both in the relatively normal lung and in the operative lung, indicating that they may actually in humans be performing the same effect that we saw in animals. Here is a patient-level outcomes of postoperative pulmonary complications in patients undergoing lung cancer surgery. So they've had the same beaten up walls. And you can see there's the Propofol column on the left, the sevoflurane column on the right, and there's a significant reduction in postoperative pulmonary complications. And the patients who had postoperative pulmonary complications, there were fewer in the sevoflurane group. So this is a larger study, 174 patients, and I think does demonstrate the protective effect of sevoflurane. Is there a dose effect? So this is data from 3 hospitals in Boston, over 100,000 patients. And here you can see that the odds ratio for postoperative pulmonary complications decreases with the effective dose of inhaled anesthetics. So that goes further to proving, Koch's postulate. Not only is the effect there, but it's a dose effect. So it further strengthens the hypothesis that there is pulmonary protection from inhaled anesthetics. This is a paper from Germany showing how that may influence the pulmonary mechanics. So here we can see the driving pressure of patients undergoing sedation with inhaled anesthetics. The orange line being the patients that received inhaled anesthetics, and driving pressure drops over time, while the patients who did not receive inhaled anesthetics, driving pressure seems to remain the same. And if you remember the concept of driving pressure, this is tightly associated with mortality, okay? So not only are we seeing reduction in inflammation, we're also seeing perhaps something that may be related to mortality. So going further, this paper was presented earlier. This is 200 surgical ICU patients, and after adjusting for multiple confounders and doing the best statistical job you can never be perfect, showed a substantial decrease in mortality or increase in probability of survival when inhaled anesthetics are used. Now, sedation is important, but why would this be? It's not from being able to wake the patient up quicker. There must be, in my opinion, some sort of protective effect from the inhaled anesthetics themselves going on here. And this is, I think, the most important article in the field right now, and we have the author with us here today. A randomized controlled trial of 50 patients in France, patients with moderate ARDS by Berlin criteria, randomized to sedation either with sevoflurane or midazolam. And what they found is that they had improved oxygenation in the sevoflurane group. Again, assuming the ventilation is similar across both groups, why would this be? Reduction of inflammation, preservation of the architecture of the lung, and leading to an improved clinical outcome. These investigators measured S-RAGE, which is a very good marker of lung injury, and they measured it in the plasma and found that that was reduced on day 2 in the patients who received inhaled anesthetics. And they interestingly also did a bronchoalveolar lavage and measured it in the lung itself, so thereby confirming that it was a reduction in lung injury rather than from another source. So what were the outcomes of these patients? Well, it was a small trial, 25 in each arm, so there was really no difference in the clinical outcome, but that doesn't mean that we won't see one in a larger trial. And I would say that based on the evidence, both from the operating room and from the ICU, a larger trial targeting lung protection is warranted and important. So here's a meta-analysis by Angela Jareth looking at time to extubation. Now, time to extubation may be sedation related, okay? So if you have a decrease in 1 hour or 2 hours in the time to extubation, that could be sedation related. But I think we really have to consider that if you're seeing a 20-hour reduction in time to extubation, it's not only sedation related. That is an improvement in lung function related to the anesthetic. So here you can see all agents compared, so volatile compared to intravenous midazolam or propofol, indicating a superiority of inhaled anesthetics. Here you can see it's even greater when you compare to intravenous midazolam, and that would be expected because intravenous midazolam, even though it's on bolus, it's a short-acting drug. When it's given continuously, the pharmacokinetics change and it becomes a much longer acting drug. But this is the most interesting part. This is a comparison between volatile anesthetics and propofol. Now, I don't know about your practice, but propofol is a pretty good sedative agent, and people reliably wake up quicker with propofol. So if we're seeing a difference in time to extubation compared to propofol, I would argue that that is more lung protection than improved sedation. Okay? This is a meta-analysis from the operating room. So Ullig from Germany published this. This is in cardiac surgical patients, studies targeting using inhaled anesthetics versus Tiva, which is usually propofol in these days, and showing a significant reduction in pulmonary complications. So again, maybe sedation related, most likely there is something else there. And this, I think, speaks even more to that. So this is a significant reduction in mortality in patients receiving inhaled sedation in the operating room compared to patients who received a total intravenous anesthetic. So, plausible that it's sedation related, more likely it has to do with organ protection from the inhaled anesthetics. So that's why this talk is titled Inhaled Anesthetics, Killing, but probably should be said, Saving Two Birds with One Stone. So these are more than just drugs that put people to sleep. We really have to carefully study the non-sedative effects of inhaled anesthetics, and expanding the therapeutic use of inhaled anesthetics in the ICU actually has in my opinion, a chance of being a real game changer in the ICU, because we save two birds with one stone. Thank you very much.